Friends, PharmaLife Academy, an academy for pharmacy and pharmacology, presents a tutorial video on antifungal drugs part 2. Friends, in previous part, that is part 1, we studied definition, classification, mechanism of action of various antifungal drugs and details of amphotericin B, capsofungin, grisofulvin. In this part, we will study the details of Azole Antifungals, Allylamine Antifungal and Tolnaftate. Azole Antifungals. Azole antifungals are effective against Candida albicans, Candida tropicalis, Candida parasilosis, Candida glabrata, Cryptococcus neoformans, Blastomyces dermatitidis, Histoplasma capsulatum, Coccidioids species, Paracoccidioids brasiliensis, and ringworm fungi. They are less effective against Aspergillus species, Pseudosporium apiospermum, Fusarium, and Sporothrix schenki. They are not effective against Candida crusei and the agents of mucormycosis. Itraconazole, an azole antifungal drug. It is fungistatic. Oral absorption of itraconazole is variable. It is enhanced by food and gastric acid. Its volume of distribution is 10 liter per kg. It accumulates in vaginal mucosa, skin and nails, but penetration into CSF is poor. It is largely metabolized in liver by CYP3A4. An active metabolite is produced which is excreted in feces. Its half-life varies from 30 to 64 hours. It is well tolerated in doses below 200 mg per day. Gastric intolerance is significant at more than 400 mg per day. Side effects include dizziness, pruritus, headache, and hypokalemia. It may cause transient rise in plasma transaminase. Impaired left ventricular function has been worsened in some patients. Drug interactions of itraconazole. It is CYP3A4 inhibitor, antacids, H2 blockers and proton pump inhibitors reduce its oral absorption. Rifampin, phenobarbital, phenytoin and carbamazepine induce its metabolism and reduce its efficacy. Clarithromycin and HIV protease inhibitors reduce its metabolism, raise its blood levels. Its administration with estimizole, cisapride and class 3 antiarrhythmics can result in ventricular arrhythmia. It increases phenytoin, digoxin, sulfonylureas, statins, dihydropyridines, protease inhibitors, warfarin and cyclosporin plasma levels. The capsule form of the drug is best absorbed in the fed state, while the oral solution is better absorbed in the fasting state. Therapeutic uses of itraconazole. Itraconazole is preferred for most systemic mycosis that are not associated with meningitis. It is superior to fluconazole for stoplasmosis, blastomycosis, sporotrichosis. It is the drug of choice for the rare fungal infections such as paracoccidioidomycosis and chromomycosis. It is also used to treat aspergillosis. Its normal dose is 200 mg OD or BD with meals for 3 months or more. For vaginal candidiasis, its dose is 200 mg OD oral for 3 days. This is as effective as intravaginal clotrimazole. For dermatophytosis, its dose is 100 to 200 mg OD for 7 to 15 days. In this condition, itraconazole is more effective than grisofulvin but less effective than fluconazole. For onychomycosis, its dose is 200 mg per day for 3 months. An intermittent pulse regimen of 200 mg BD for 1 week each month for 3 months is equally effective. In onychomycosis, relapses have occurred after itraconazole therapy, though it remains in the nail for a few months after completion of the course. The next azole antifungal drug is ketoconazole. Itraconazole have largely replaced ketoconazole for systemic mycosis. Ketoconazole is available as shampoo, cream, foam, and gel. Indications for ketoconazole are cutaneous candidiasis, tinea cruris, tinea pedis, tinea corporis, tinea manum, pityriasis versicolor, seborrheic dermatitis, and dandruff. Next, azole antifungal drug is clotrimazole. Clotrimazole is effective in the topical treatment of tinea infections like ringworm, athlete's foot, otomycosis, and oral cutaneous vaginal candidiasis. It is particularly favored for vaginitis. Indications are oropharyngeal candidiasis, fungal otitis externa, skin fungal infections, vulvovaginal candidiasis. Local irritation with stinging and burning sensation may occur with topical use of clotrimazole, and recurrences are common after all regimens. Luliconazole is the latest topically used azole antifungal drug. Luliconazole cream 1% is indicated for the topical treatment of interdigital tinea pedis, tinea cruris, and tinea corporis caused by the organisms Trichophyton rubrum and Epidermophyton flocosum. Luliconazole cream 1% is not for ophthalmic, oral, or intravaginal use. A thin layer of luliconazole cream 1% should be applied to the affected area and approximately 1 inch of the immediate surrounding areas. Duration of treatment: interdigital tinea pedis once daily for 2 weeks and tinea cruris or tinea corporis once daily for 1 week. Next antifungal drug, terbinafine, belongs to Allylamines class of antifungal drug. Terbinafine is fungicidal. It is effective against dermatophytes and candida. Its efficacy in nail infection is higher than bisulfulvine and itraconazole. It is less effective for cutaneous and mucosal candidiasis, and in these conditions it may be used as an alternative to fluconazole. It is orally and topically active. Approximately 75% of oral terbinafine is absorbed, but its bioavailability is decreased to approximately 40% because of first pass metabolism in the liver. Terbinafine has high affinity for keratin. It gets concentrated in sebum, stratum corneum of skin and into nail plates. Its initial half-life is 11 to 16 hours but is extended to 10 days after repeated dosing. Terbinafine is not recommended in patients with marked azotemia or hepatic failure. Therapeutic uses of terbinafine. Terbinafine is used to treat tinea pedis, tinea cruris, tinea corporis, tinea capitis, pityriasis versicolor, onychomycosis, and cutaneous and mucosal candidiasis. Side effects of terbinafine. Side effects upon oral administration: gastric upset, rashes, taste disturbance, and less commonly, hepatic dysfunction, hematological disorder, and severe cutaneous reaction. Side effects upon topical application: erythema, itching, dryness, irritation, urticaria, and rashes. Drug interactions with terbinafine. Terbinafine does not inhibit cytochrome P450. Enzyme inducers decreases and enzyme inhibitors increases its steady state plasma levels. Rifampin decreases and cimetidine increases its plasma concentrations. Tolnaftate is the next drug that belongs to the class other topical antifungal agents. Tolnaftate is effective for tinea cruris and tinea corporis, and most cases respond in 1 to 3 weeks. It is less effective in tinea pedis and other hyperkeratinized lesions. It is ineffective in tinea capitis and tinea inguinum. It is ineffective against candida. It is inferior in efficacy to imidazoles. It is available as 1% cream, gel, powder and topical solution. The preparations are applied locally twice a day. It causes little irritation. Friends, are you ready? Check your knowledge of antifungals. Solve the test paper which is available on our Facebook page. All the best.